So today here we are going to start with our new topic, that is tuberculosis. It is a topic of every subject and it is also considered as most important, but here we will learn in the community medicine. So basically it affects the lungs, then it is known as pulmonary tuberculosis, and if it is affecting intestine, meninges, bones, joints, skin, lymph glands, then it is known as extrapulmonary TB, and if it is affecting the cattle, then it is bovine tuberculosis. Some points which you should know, just like TB, it is a barometer of the social welfare, and it is 95% that are globally contributed by the middle and the lower income countries. And the most common death cause of death among the people living with HIV is also TB, and it is also associated with the smoking, and the 10% cases are smokers. Now it is TB, it is associated sometimes with the diabetes, and for the screening by the non-communicable disease by ASHA, it is only for rupees 10 for one form field. Now let's see the agent factors responsible for it. So agent, most common agent, that is Mycobacterium tuberculosis, which is acid fast stain positive, and it is due to the acid fast due to the presence of the mycolic acid present in their cell wall. And other acid fasting positive examples are nocardia, isospora, and mycobacterium leprae. So some of the atypical mycobacteria, there are typical and atypical mycobacteria, and atypical, it's Mycobacterium tuberculosis, Isospora, Mycobacterium leprae, and atypical are photochromogen, scotochromogen, non-photochromogen, and rapid growers, that are Mycobacterium kansasi, Scrofolisum, then intracellular, and Mycobacterium fortutum. Now, what is the difference? First of all, let's see the difference part. The typical one is highly virulent and can infect the healthy lungs, and it can spread from human to human only, and also sensitive to the standard antimicrobacterium drugs like isoniazid or streptomycin. But the atypical one is less virulent and it is capable of infecting diseased lungs, that is, the lungs with congenital deformity or the cystic fibrosis, and there is no evidence of direct human to human spread, and it is also usually resistant to standard antimicrobacterial drugs, and the typical one is considered as slow growers, whereas atypical one are considered as rapid growers. Now let's discuss the pigment part. All are pigment non-producer, but the atypical one, as we have seen earlier, that it is photochromogens, scotochromogens. Okay. Now, what are the sources of infection? Now, source of infection is sputum of a positive case who has either received no treatment or has not been treated completely, can be source of infection, and the reservoir is humans only. Mode of transmission is droplet for more than 5 micron, and droplet nuclei can be transmitted through airborne, and the bovine tuberculosis source is drinking infected milk. Now, what are the host factors? Host factors are like age, 15 to 54 years, most commonly of infecting the male, and the predisposing factors are malnutrition, lower socioeconomic status, overcrowding, poverty. Now, some of the environmental factors, such as the predisposing factors, such as we discussed. Now, the pathophysiology part, that is, if there is the primary tuberculosis, then there will be lesion at lungs during first infection, that is known as Gons focus, and Gone focus plus lymph nodes, then it will be known as Gone complex. And if there is calcification, then it is the Ranke complex. Now let's divide it into the three categories, such as healed tuberculosis, latent tuberculosis, and progressive. Healed one is 95%. In that person, there is no treatment required. But in latent TB, that is 4 to 5%, person is infected with bacilli, but bacilli is not active, and person is not infectious. In that case, 5 to 10% latent TB cases that are reactivated to active tuberculosis. Under stress, there is reactivation of the Gons complex and there is spread to the apex, and which results to a formation of a cavity, that is reactivation of the TB. Now the progressive primary tuberculosis, it is seen in the immunocompromised individual, and there is local inflammatory response with the fever, cough, and chest pain. Now secondary TB, that is due to delayed hypersensitivity reaction and the cavitation at the apex with caseous necrosis. Now some of the complications, such as complication is miliary TB. Okay, now any TB positive person not on treatment can spread disease to 10 to 5% per year. Now let's come on to the diagnosis part. So investigation of choice for screening of TB in a community. For it community, that is sputum microscopy. But the investigation of choice for the people living with HIV, that is the CBNAT. Okay. Now for mass screening, as we discussed, there is sputum, in which we can show the presence of TB bacilli. Red acid fast bacilli on blue background is seen. Okay, and the turn around time, that is 24 hours. It is of low sensitivity. And for the sputum samples, there are two samples collected. First one is on the spot collection and another one is next morning. And what is the quantity of it? It can be more than 5 ml. If one sputum sample positive person can spread, person is positive for pulmonary TB. Only if sample is positive, then the person is positive for pulmonary TB. For the disposal of sputum, here we can see that the disposal of sputum, it is on a household level. Just collect the sputum on a piece of paper, and then burn it. And for that, in the facility level, tube take a tube filled with 5% cresol is taken, spit on the tube, and leave for 12 hours. Now in the bigger hospitals, for the disposal, there is incineration. Now sputum smears are stained with the for the acid fast bacilli with zealand, and the decolorizer used, it is sulfuric acid, and the counter stains are Loeffler's methylene blue. So the investigation of choice for the TB in the people of HIV, as we know that it is CBNAT, and the TB suspected baseline sputum microscopy plus CBNAT plus chest X-ray, and the first choice for case finding tool for TB, for the mass screening of TB, that is sputum microscopy. Okay guys, thank you so much.